Hello, everyone. This is Sherry from the CGH Health Foundation, and you're seeing me right now because this is one of our Growing Healthier programs, one of our series of free community education programs. So this month, our speaker is Tracey Aude, who is a nurse practitioner with the CGH Cardiology Department. And Tracey's going to be talking with Dr. Bird about our heart failure program that helps patients with advanced heart failure relieve some of their symptoms. Before I hand it over to Dr. Bird to talk with Tracey, I'd like to tell you about next month's program. As you might remember, the mission of the CGH Health Foundation is pursuing healthier lives for people of the Sauk Valley. And this year, we're focusing on the youngest members of our community, infants and children and their mothers. August is Breastfeeding Awareness Month. And so for next month, we have invited Vanessa Simonton, the director of CGH's Maternal Child Services, and Marcella Sproul, who's one of our registered nurses in the birthing center, to come and talk about our pre and postnatal classes, including our breastfeeding classes that we offer at CGH. So be sure to watch next month on August 19th at noon for our next Growing Healthier program. And with that, I will turn it back over to Dr. Bird.
Thanks, Sherry. Hey, I took a week off. Glad to be back. I hope everybody can hear me okay. I've got a new mic. I'm sure Matt will let me know if we have an issue with it or when I get Tracey on here. But today, oh, by the way, this is Bill Bird. I'm the Chief Medical Officer at CGH Medical Center. Thanks for joining me for this broadcast today. So today we're going to talk about heart failure. And have a lot of questions to ask of Tracey Aude, one of our folks who is very involved in heart failure at the clinic. And before I get Tracey on, I just want to kind of outline that of what we're going to do today. So we're going to mix it up a little bit, and I'm going to ask questions of Tracey first. And then once we get done with talking about heart failure with Tracey, then I'll give a brief update about COVID and what's latest and greatest here in Whiteside County and across the country and world. That'll be pretty brief. So without further ado, let me get Tracey on here. There's Tracey.
Hello.
Hey, can you hear me okay, Tracey?
Yeah.
Okay, good. Okay, so Tracey this is terrible, Tracey. You're a nurse practitioner?
Yes.
All right, I lose track of that sometimes. She's a nurse practitioner, has been with us for a long time. Not that she's that old, but she's been with us for a long time in the cardiology department, and wanted to have Tracey on here today to talk about heart failure. So you ready for a few questions, Tracey?
I'm ready.
Okay, all right. So first question, what exactly is congestive heart failure?
Heart failure is basically a condition where the heart is just not able to pump blood as well as it should.
Okay. Yeah, so the muscle just doesn't pump the way it should. And it's my understanding there are a couple our heart has two pumps, basically, right? Left and right ventricles.
Yes.
So in that respect, there then are two pump possible failure sites. One is the left side and one's the right side. What's the difference between those two, Tracey?
The right side pumps blood to the lungs. So symptoms typically for that will be peripheral symptoms, swelling in the abdomen, the lower extremities. The left pump, basically symptoms would be shortness of breath. You'll see swelling probably in the left side first, weight gain, chest discomfort. You may have fainting spells, fatigue, cough, wheezing.
Yeah. Of the two, which is more common?
Left-sided heart failure is more common.
Yeah, that's the kind of when most people, when we talk about heart failure, not always, but most people, when we talk about heart failure, we're typically talking about that left-sided pump. Just so folks are aware of that. And there's a lot of patients that you monitor there at the clinic that have heart failure, I know. So when they between their visits, Tracey, what do you recommend in terms of monitoring of themselves between visits to make sure to kind of get if they're kind of starting to build up fluid, how do you have them check that out?
So what I normally do is have them weigh daily in the morning. As soon as they get out of bed, they go to the restroom. As soon as they're done with that, they weigh in their pajamas. So they have that same weight every morning. They have to watch that. They watch their salt intake. I try to limit them to usually no added salt. If they have trouble with that, then I just limit to 2 grams of sodium a day, which would be 2,000 milligrams of salt. You would look at the back of the label of food items, and you can look at the serving sizes and add that up through the day. I have them look for increasing shortness of breath, difficulty laying down in bed to sleep, swelling, weight gain of 3 pounds or more in a day, or 5 pounds in a week. They'll let us know here at the office so we can make adjustments in their water pills if needed.
Okay. Is everyone sensitive to salt, or what's the deal on that, Tracey?
Typically, some people are more sensitive than others. I found more like with diastolic heart failure patients where the heart doesn't relax well.
Okay.
Some of those can be more sensitive, but salt causes your body to attract water, so then it will retain it. So that's the reason for the salt restriction.
Yeah, you mentioned diastolic heart failure. So let's talk about that briefly. So what is diastolic heart failure versus what we call systolic heart failure, Tracey?
So diastolic heart failure is where the left heart pump is normal, but the heart itself cannot relax to fill the chambers to move fluid forward in the system. Systolic heart failure is where the left side of the heart, the left ventricle, loses its ability to pump strongly to eject enough blood that the body needs to keep the fluid moving forward.
Okay, yeah, that makes sense. So like the diastolic, I would think of it almost like as you can pump water out of the can, but you just don't fill the can up as far.
Correct.
And the systolic is you fill the can up as much as you want, but it just doesn't. You're not going to get everything out that you want. So okay, that makes sense. Yeah. So we've talked about salt. Anything else dietary wise for heart failure patients that you tend to recommend, Tracey?
I usually will talk with them about limiting their baked goods because when you have baking soda in the baked goods, when you eat that, it turns into salt in the body. So they need to limit that as well.
Yeah, that makes sense. Well, that's a bummer. A lot of people are probably like, oh, no, can't have my morning muffin.
Yeah, no, they don't usually like that.
All right. So what did I want to ask? Oh, yeah. So what are some conditions? Because heart failure is just it's a condition, but it tends to be caused by other stuff. So what are some conditions that can lead to your heart failing, to heart failure?
So years of uncontrolled high blood pressure, it places a strain on the heart muscle itself. So when that left ventricle has to pump against a great amount of pressure, it weakens over time. So that can weaken the heart muscle.
I'm just curious, Tracey, I'm going to stop you on that. So if you do have hypertension and you start to get heart failure, what kind of heart failure do you tend to get? Is there a tendency towards either the systolic or diastolic one?
Systolic.
Okay. Okay. All right. What other causes?
Blockages in your arteries of your heart can cause the pump to start to fail. And that can be reversible if we can fix the vessels. Valve issues in your heart, you have several valves. If those valves start to leak or start to get narrow, then it can cause heart failure over time. And abnormal heart rhythms. Certain abnormal heart rhythms can put a stress or a strain on the heart muscle and can cause the heart to get weak.
Okay. Yeah, so it's not one particular thing. It's just multiple things, which goes to my next question. So, so someone you have a patient you see and you diagnose them with heart failure. What kind of testing do you do to try to figure out what is causing it?
So typically we do an EKG, and that's just an electrical conduction system test where we can see what the electrical conduction system is, so which would be the irregular heart rhythm part. We do ultrasounds of the heart, and that would check the valves, the heart structure, and the function of the ventricles. Holter monitoring to see if you do have some irregular rhythms, how frequently they are occurring. Sometimes if they're very frequent, then that can lead to the pump failure.
Okay.
Stress testing, which looks for blockages in the arteries of the heart. You sometimes will have to have an angiogram if that testing is abnormal, and that's where we go in with a catheter to look inside the blood vessels of the heart for blockages. You can do a chest x-ray looking for fluid in the heart and then the size of the heart itself.
Okay. Any other lab tests that you would do for someone who's fairly new to heart failure?
Lab testing, I typically will do, kidney functions, albumin to check proteins. They're having irregular heart rhythms, magnesium levels, electrolytes, a blood count to see if their blood counts are low or not, because that
Sure.
can worsen heart failure.
Sure.
And then there's BNP levels.
Well, what exactly is that, Tracy? And what's
That's
a
a blood level to check for heart failure.
Okay. Yep. Yeah. So that's a test that I would say, gosh, it seems like within maybe the past 10 years that has come out, that BN, N as in Nancy, P. It's been pretty helpful. There are other reasons that it can be elevated, but I'm guessing it gives you some decent information when you test for that.
Yeah, I think when you put things together, yeah, it's helpful.
Yeah. Yeah. Do you check thyroids out too on that initial testing?
Absolutely.
Okay.
Absolutely, yes.
Why is that? What would
Thyroid testing, if it's off, does affect the heart very much. Its function, its electrical conduction system, and the rhythms that do occur are affected by the thyroid. So
Yeah.
we definitely need to have that in check.
Okay. Do some people who have heart failure need a defibrillator?
Yes, some people do.
What's the deal with that? Who would need a defibrillator? And that's a defibrillator, by the way, is a device that would shock your heart back into a rhythm again, just for those who are listening.
Yes. So if you have a weakened heart muscle, and the weakened heart muscle is below 35%, and you have limitations in your physical ability, and or if those physical limitations cause you symptoms, you may be a candidate for a defibrillator. If you have a heart attack and the pumping ability is less than 30%, you'd be a candidate. Or if you're having irregular heart rhythms that put you at high risk for passing out or sudden death, you would be a candidate. Pumping abilities of the heart are normal in the 50 to 55% range.
Okay.
So less than 35, less than 30 puts you at high risk for certain irregular heart rhythms that can cause sudden death.
Okay. So it messes up your electrical system if your heart doesn't pump that great.
Correct.
Yeah. Yeah. And what else was I going to mention? I was ask you about that. As far as the defibrillator goes, I'll think about it, but I'll think about it again. Let me ask you another question. Let's talk about medications that you use for people that have heart failure. So what are some of the medicines that you patients end up being on oftentimes who have heart failure, and why? Why are they on those different medicines?
So we use water pills to limit fluid retention. Those are basically just for symptoms. Some people don't need water pills that have heart failure. It just depends on how your body responds. Beta blockers we use. Those slow the heart, lower the blood pressure, and improve the heart pump.
Okay.
And they reduce your risk of death from irregular heart rhythms.
Okay.
ACE inhibitors, those widen your blood vessels and improve blood flow, which decreases the workload on the heart that it has to pump against when it pumps the left ventricle.
What would some of those be like? What would be some of the generic names for the ACE inhibitors, by the way?
Oh, lisinopril, Acupril.
Okay.
We do use ARBs in those places if the patient has side effects from the ACE inhibitors, and those would be losartan, Diovan, candesartan.
Sure. And I should probably ask you the same thing about the beta blockers. What are some common beta blockers that patients are on for heart failure?
Carvedilol is a special type of beta blocker that's a vasodilator. And it's usually our first drug of choice, but if we're unable to use that, we'll use metoprolol at high doses if possible. And then bisoprolol is another beta blocker we'll use for people that have lung disease.
Sure. What other meds are there, Tracey?
Aldosterone inhibitors like Spironolactone is a very good drug, especially for diastolic heart failure, but with systolic heart failure, it's been proven to reduce mortality or death rates.
Yeah, how does that work? How does that spironolactone do what it does to help people out?
It reduces your fluid retention and helps the kidneys get rid of excess fluid. In doing that, it does retain a little bit of potassium, so we have to watch as far as the kidney functions and what your potassium levels are in order to balance those things.
Yeah. Yeah, if you know, at least the patients I have, sometimes it can be a little tricky because you're trying to keep people dry is the word we use, right? Try to keep them dried out, but not so much so that it hurts their kidneys or affects their potassium.
Correct.
Yeah. How often?
And the combination with the ACE inhibitors, raising the potassium as well.
Exactly. Are there any, besides the spironolactone, are there any newer drugs or infusions that you're using these days for folks who have heart failure?
Yeah, we're using a drug called Entresto.
Okay.
And it has a component of an ARB, which is what we kind of talked about before, like the Diovan, candesartan, that type of drug. But it also has a drug in it that sacubitril that helps with fluid retention. So typically, if we start that drug, we kind of have to know our patient and decide if we can lessen the diuretic dose, because it does work really well with fluid reduction.
Okay. So that's, if you've tried all these other things and you're just not quite getting there, that's when that medicine is where you put that into play, that infusion.
That is an oral tablet. And what I normally do is I'll start just with Entresto right away if their EF is pretty low and their kidney functions are okay and potassium's okay, that we can initiate it.
So when you say EF, what does that stand for, Tracey?
The pumping ability of the heart.
Ejection fraction then is the fancy word for EF.
Correct.
Yeah,
sorry.
Okay. That's all right. All right. Hey, I want to talk a little bit about even beyond the medications. You know, some patients, despite all that, the hearts just don't pump well. There's something called an LVAD that I know that you send folks to have once in a while. Can you kind of talk about what exactly that stands for and what it does and what kind of patients are candidates for that device?
Okay. It's called a left ventricular assist device. It's a mechanical pump that's placed in the left side of the chest, in the left ventricle, to help a weakened heart pump blood. So it kind of takes the place of that left ventricle pump. It takes that over. Patients with end-stage heart failure that have significant limitations in their physical activity are candidates, usually class 3 and class 4 heart failure patients, meaning that they have very significant limitations, even to the point where they can't do much at all. And if they do anything, they get severely short of breath, winded, have chest pain.
Yeah.
You're a candidate if you are class 3 or class 4 and have those symptoms. generally won't consider people that have kidney failure, serious brain injuries, severe infections, liver disease, any clotting problems, or lung disease. You do have to be on blood thinners. Like
Once you start the pump? Okay.
Yes, once you start the pump.
Yeah, and my understanding is that
lead,
yeah,
not a candidate.
Yeah, my understanding, Tracy, is that it literally is a electric pump that
Yes.
kind of hooks up, and I don't, I'm not a cardiothoracic surgeon, but it's, yeah,
they're very neat. Yeah. We've had several patients locally who've had them.
Yeah, and what's your experience with those patients that are on those? How does it help them in terms of their ability to function?
Yes. Yeah, we've had several live for 2-3 years beyond their expectancy.
Yeah. So beyond the pump, Tracy, my understanding is the next step for some people is a heart transplant. So can you talk a little bit about that, and who gets a heart transplant? What do they have to have going on that would make them a candidate for that?
So that would, again, be end-stage heart failure with less than a year to live.
Okay.
Without a transplant, and if they've failed medical therapy and or are not a candidate for an LVAD, which is the left ventricular assist device. And those, the devices can be used as either a bridge to therapy. You can use that to bridge them until they can get a transplant, or that can just be a destination where they can be on that for several years, even if they're not a candidate for a transplant.
Yeah.
Patients that would be candidates would be people with a weakened heart muscle, with the limitations that I had described before with the left ventricular assist device, that they can't really do much physically at all. Class 4 angina, which is they have to be on medical therapy and they are unable to be revascularized. So we can't do anything more for them to fix the blockages in their heart. We can't stent them. We can't bypass them anymore. They would be a candidate.
Is there an age cutoff on that, Tracy, or a health cutoff that, you'd say, eh?
Yeah, I mean, they generally, most people are reasonable. I mean, people in their 80s will say, they're not going to do that. They're not going to go through that. We've had people in their 70s have transplant. But yeah, you need to take a definite look. There's not really a definite age cutoff. You need to take a whole, consider the whole picture of the individual and all their comorbidities, which means all of their other health problems. Yeah.
Good. So that's good to know. And just as an example, I was reading an article. The former Vice President Cheney, he, I think it was like 2009, he got an LVAD, which held him over for a year or two, and then he got a transplant. So he's been living with a transplant for close to a decade. So yeah, it's kind of how that can go down that way. Matt, would you put that question back up on the screen? One of our viewers sent us a question from Kelly. So how about treating, healing, and sometimes reversing heart disease with whole food plant-based instead of all these medicines? What are your thoughts on that, Tracy?
Yes, absolutely. I've seen people that have switched to the whole foods plant-based diet, definitely reverse it. Their numbers can be very, very good. But the problem is most people just can't stick to it, and most people won't even consider it.
Mm-hmm. Yeah. So is that kind of a form of like the Ornish diet or something along those lines?
Ornish is more like eat lots of protein and meat.
I thought that was Atkins. I'm thinking Ornish is more of the guy who did the it's more like herbs and roots, and it was pretty. Anyhow, so this whole getting back to our question, this whole that can be really helpful. Okay.
Yes.
Yeah. So to Kelly's question, then I guess the answer is potentially yes. It's just a matter of the patient's ability to do that. And gosh, I would even add to that, Kelly, that the best thing you can do with about heart failure is to not get it. And so,
Prevention, yes.
Yeah, to stay healthy, to eat a healthy diet, a diet that is, maybe you may have some meat in it, but it's not a lot of meat. And it is a lot of plant-based stuff. And you exercise. Those are the kind of things that keep you out of Tracey's office for as long as possible. So good question, and good answer. Thanks, Tracey, on that. So cardiac rehab, I want to talk about that a little bit too. So of these heart failure patients, who goes to cardiac rehab of that group of folks that you see?
Patients that have had heart attacks, patients who have had revascularization, meaning a stent or bypass surgery.
Yeah.
And some heart failure patients can attend rehab if they are able to do some form of exercise.
Okay.
If their pumping ability is very low, generally they're not a candidate. They just aren't able to do that. It puts them at higher risk for irregular heart rhythms to strain or stress the heart that much, but they can do daily activities fine.
Yeah. Speaking of activities, Tracey, how do you decide, or how do you recommend to patients who have heart failure how much activity they should take part in? How much should they do?
If their pumping ability is less than 30-35%, limit what they can do as far as recreational sports and stuff. No. Just activities of daily living and symptom limited. Listen to their body. If their body's telling them they need to rest, then they need to rest.
Yeah. So do what you can, if is basically what I'm hearing there.
Mm-hmm.
Yeah. What you feel like you can do. Okay. Good. Oh, I know. I wanted to go back to that defibrillator. My mind just kind of blanked on what I was going to ask you. So my understanding on the defibrillator, is there, if you need one, if you're a candidate for one and potentially should get one because of your risk of having arrhythmias, are you supposed to wait a period of time before you get that defibrillator? And why would you wait before getting that?
The only time that you would is if the pumping ability is low and we feel that it's going to possibly recover, like after a heart attack or after revascularization. We look at waiting, about 40 days or so for that to recover, and rechecking the pumping ability to see if that has recovered or resolved.
Yeah. So if they bounce back up, let's say from 35% to 45%, then you don't need to go that route.
Correct.
Okay. Good. Well, Tracey, we've covered a lot of ground here in a pretty short period of time. Appreciate it.
Yeah.
Before I let you go, so do you have actual blocks of time when you have just heart failure patients that you see, or do you kind of mix them within the other patients that you see in your clinic?
I mix them.
Okay. Yeah. And is that the same for all the folks in our cardiology office? They tend to have, there's not a set, it's not like Mondays or heart failure days.
Nope.
Okay.
They just have the same appointments as everybody else.
Great. Well, Tracey, thank you so much for taking the time to join me. It's been very informative, and thanks for your time. And I'll let you get back to, I'm sure you have some stuff to take care of in clinic this afternoon.
Yes, thanks for having me.
You bet. Thank you. Okay, so I wanted to give a brief update on COVID. So obviously the thing that continues to play out is this Delta variant, which is more contagious, and it appears that it can get people sicker. I think the biggest risk for the Delta variant is people who have not been vaccinated. And for instance, I was reading in Southwest Missouri, they have a pretty low vaccination rate, and so they're having an outbreak. I suspect it's of the Delta variant, and people that are younger, like 20s, 30s, and 40s are the folks are getting sicker and having to be hospitalized. It seems so far, at least with the Delta variant, that if you've had a vaccine, that you're pretty well protected, at least from getting really, really sick and having to be in the hospital. So that's still good news in terms of the vaccines. So as always, I encourage folks to get vaccinated. I had a conversation with someone today who was still back and forth about whether or not to get the vaccine. And So there are still folks out there in that camp, and if you're one of those people, gosh, it's still not too late. It's still, I know at CGH we still have a vaccine clinic that's going Monday through Friday from 8:30 to 2:30 at the main clinic. So it's a walk-in clinic. So please take advantage of that. We're giving either the J&J, which is the one-shot COVID vaccine, and we're also giving Moderna, which is the one shot and then another shot a month later. And so I really encourage folks to take that advantage of that, and or the health department continues to have clinics as well. So otherwise, thank you for listening, and hope you have a great 4th of July weekend. And I will be back to talk with all of you next Thursday. Until then, take care.